the Mayo Clinic in Rochester and did additional fellowship training in congenital cardiac congenital surgery in Loma Linda. Since that time, he's been at the Mayo Clinic. He has been a colleague and friend. I'm impressed. He's an amazing family man. He's a hell of a saxophone player. But what is really neat for me as a surgical educator more than anything, he is meticulous about his own performance of his trainees, performance of his team. He doesn't accept less than perfection. We can never get there, but he is always trying. He is going to give this presentation remotely and will answer questions if you have them, and I hope you do. He's going to talk about perfection and elite performance in surgery. My friend and colleague, Dr. Joe Deraney.
Welcome, and thank you to Dr. Farley for the very kind invitation to speak on a topic that I am passionate about, elite performance in surgery. It's a pleasure to be here. I look forward to hearing your comments at the end of this presentation. To me, the quality operation as it relates to elite performance is doing the right thing, which is effectiveness, and doing it right or correctly the first time, which refers to efficiency, improves outcome and will ultimately reduce cost. In surgical training, practice makes, to my mind, almost perfect. And when this paper was written a couple of years ago by one of my colleagues and I, Dr. Stulak, we felt that the most important elements to achieving near perfect surgery is critical thinking skills, judgment, technical abilities, grit and perseverance, and intellect. The one thing we did not talk about was emotional intelligence, which I think is another variable which also plays into elite performance. I'd also like to mention that, at least for cardiac surgery, in particular in congenital, public reporting and transparency of outcomes by institution and forthcoming also by surgeons is front and center now. And this is going to take effect really for all specialties. So the pressure is on. The story of cardiac surgery begins with the first 50 years being marked by the introduction of new operations. But I believe the next 50 years will be marked by achieving near perfect outcome for these well-documented and proven operations. And this is how I believe we will do it. Elite performance and the structure of this presentation is going to revolve around advances in imaging, the importance of practice, communication and listening skills, what exactly happens in the operating room theater, and then the post-self-assessment and debriefing, and finally, what I believe will be forthcoming with the examination and certification processes. Advanced imaging is now present, and I believe it is helping surgeons. Certainly, it is being quite helpful in the congenital cardiac surgical arena. We've worked very closely with our imagers, and this dates back actually many decades ago. Dr. Jules Ruud is an elite cardiac imager, and actually, to his credit, he has come up with suggestions for operations that have been helpful to surgeons. So work closely with your imagers. They have a lot to teach us, and they can also stimulate ideas for new, different, or modifications of operations. Anatomic models reflect the unique anatomy. It contributes to surgical care and outcome by doing the following: focusing pre-surgical decision-making. It can become a reference during the actual operation. Preparation will ultimately shorten surgical procedural time, and I think it will help us do standard operations better. And it is an educational tool for the patient, family, and other healthcare providers. And in cardiac, you can see here that the differences between two-dimensional and three-dimensional echo, as well as cross-sectional imaging with CT and MRI, as well as cardiac catheterization, all provide complementary feedback. And it's important to know which ones are going to be most helpful for which problems. It also gives us the opportunity to actually do the operation before doing the operation. This is an example of a septal myectomy operation. It's a very short video, and it's a very difficult operation to teach because the only person that can see what's going on is the person that's doing what you see here. And this is excising muscle immediately beneath the aortic valve. You can see the aortic valve cusps just above. We're pointing out the hypertrophied ventricular septum and the contact between the mitral valve and the thickened septum that is obstructing the exit of blood flow out of the heart. And so this is a manual excision of this hypertrophied muscle that is done in a manner that does not injure either the aortic valve or the mitral valve. And again, very difficult to teach because you cannot see exactly what the operator is doing short of the operator, him or herself. This is an example of how advanced imaging is helping the surgeon. This was a report done by the Seattle group looking at doing the operation beforehand in the operation that you just saw, where the surgeon is actually practicing on a model that was manufactured in advance of the exact patient that he will be operating on. And you can see here on the left the muscle resections that he did on the model, and you can see to the right the sort of mirror image duplication of the muscle resections that were done in real life. And it's also helpful for the procedural practice, either interventional cardiology or interventional radiology, where you can actually model what is going to be done. You can identify what the problem is, get precise measurements, and then execute it in advance. The next thing I want to talk about is practice. And Dr. Anders Ericsson, who is the one that really is credited with the 10,000-hour concept, talks about deliberate practice. And the main difference between just general practice and deliberate practice is feedback. And we've had the chance to work together on some projects over the years. And this is the difference. With simple practice that you may do on your own, you only achieve a certain level of skill which levels off. But with feedback from a supervisor or a senior surgeon or a coach or whoever it may be, you can see the ability to advance your skills becomes even greater because of the feedback that is provided. And this is a sort of gold standard reference from one of Dr. Anders Ericsson's original papers, where to become actual professional, mathematically, it takes about 10,000 hours to reach that level of skill. And anything less than that is just gradations of your way to being a near professional. And this is an example here that performance is directly related to age and hours, where it takes mathematically a certain period of time. And so by your 30s and 40s, you are sort of at the point where you are at the peak of your career, and then it levels off. But that steep rise is early on, and that's where all the hours comes in. What about the role of simulation? Well, in the medical arena, you can see here that in multiple studies, the use of simulation as a method of practice shows that you can improve performance universally at the medical student level, at the resident level, and at the staff level. So simulation is a helpful adjunct. All right, what about teams? Let's shift to teamwork now. So teams, to my analysis, consist of proper leadership and proper followership, and you need people to follow the leader. And in the operating room, there are many personnel that we are working with, and all need to communicate. Communication is key, and it involves body language, and it involves careful listening. And if you look actually at communication, it's a combination of body language, the tone and modulation of your voice and words. And interestingly, body language and the tone with which the message is delivered is far more important than the actual words that are said. With regard to listening, there is a difference between hearing and listening. Listening is focused, it's voluntary, it's intentional, and it's something that we use our brain to do. And in the operating room, this is absolutely critical. And if you look at two studies that have been performed in the last decade and beyond, we actually have a lot of room for improvement. And this is a study looking at collaboration as it relates to communication. And you can see here that through the eyes of the surgeon, we think we actually communicate quite well with the anesthesiologists, the CRNAs, and the OR nurses. But if you turn it around and look at how the OR nurses, CRNAs, and anesthesiologists perceive us, it's not quite as good. Definitely room for improvement, and this is mirrored in a more recent study that was done just a little bit more than a decade ago, emphasizing the point that the surgeon, him or herself, has room for improvement when it comes to collaboration and communication. The other point I would like to make is this sort of perceived importance of hierarchy. And whether you're in the operating room or whether you're on the ward making rounds, there clearly is, quote, a white coat hierarchy. But it is important to remember in the operating room as well as on the ward that everybody is on the same playing field. There really is no hierarchy per se. We need to be open to suggestions and comments that are being made by, quote, the lowest person on the totem pole. And barriers to speaking up include the following: fear of being embarrassed, ridiculed, or yelled at, being wrong or feeling stupid, or saying something that may not be felt to be important. Or the person that may be frightened to speak up may be thinking they're not going to listen to me anyway, or that's not important. I cannot emphasize enough the importance of everybody feeling free to speak up, whether it's something good or something concerning. And remember, they may forget what you exactly said, but they will never forget how you made them feel. So do not belittle anyone for bringing up something that may on the surface not seem important in the beginning. Situational awareness is a pet peeve for me, and it's a combination of what has happened, what is happening, and what might happening. And this all relates to a combination of observation, seeing, paying attention, listening again, and communication. This is a very important variable when we are evaluating residents and our peers in the operating room. What about the actual operation? Well, I had the good fortune of writing a paper with Dr. Erickson a few years back where we looked at the role of advanced imaging, which we made reference to earlier, the importance of deliberate practice, and this structure and improvisation continuum, which I believe contributes to approaching perfection in surgery. I want to draw your attention to a concept called chunking, which I think is very, very important, and this is storing familiar sequences or patterns. It's well known in the chess literature. Chess players, as well as athletes, they never see individual players on the field or on the board. They see patterns of how people are together, and with that, they can anticipate or know what is going to be forthcoming. And this takes place on the chessboard, in all of the sporting events, and of course, what we're talking about in the operating room. So this structure improvisation continuum consists of things, at least on the musical scale, something that is classical, highly structured, something is jazz, is improvisational. And if you think about sports, football is a bit more structured. Everything starts with a specific play. Basketball has plays, but it's a lot of in the moment and improvisation. And of course, life is a combination of both of these things. And in surgery, I think that this can be translated into something that's highly structured, is protocolized, and has steps. Everything is known. I do have a playbook, and the people in the operating room know what all the steps for my common operations are. It provides the ability to obtain reproducible results. There is a minimization of errors, and you optimize the ability to have excellent outcome. In contrast, when surgery becomes improvisational, you're adapting and flexing, and we all need to do this at various points in time in the operation. We're dealing with unknowns. The plan is frequently changing, but as a result, results are less reproducible. There's a greater probability of errors, and the outcome is much more variable. What else is important? Well, something that's structured basically has high reproducibility. Something that's improvisational has less predictability. And of course, the outcome is going to be different depending upon which end of the spectrum you are on. Master surgeons, in my opinion, make improvisation essentially look structured because of their experience. So where do my operations fall? Well, I have a series of operations, and of course there's many more on this list, that are highly structured. I can essentially do the operation with almost saying nothing during the procedure because everybody knows the steps and it's all rehearsed. And then there are operations where we are sort of figuring it out on the fly. And these operations, of course, everybody has in their practice. And then there's a potpourri of operations that are going to be a combination of both. And if I look at what advanced imaging and deliberate practice do, I believe it progressively moves everything that inherently is more improvisational to become more structured. This is one of the ways we are going to get there. And as I reflect on how I help residents with cases, basically I'm helping them mostly with cases on this side, because everything is predictable and I know what the next step is going to be, and it's very, very helpful for me to help a resident through a case, in contrast to something over here where I am figuring it out on my own, and it's more important for me to be navigating the steps of that operation. So, have a playbook and really try to orchestrate each operation like a piece of classical music. That is what I do, knowing that you will never get there, but the more you can make it like that, the better it will be. Self-critique is one of the most important personal qualities for a surgeon to have. You learn from mistakes, M&M conferences, talking with your colleagues offline about maybe what you should or could have done in the operating room. And you should be interested in this, and you need to be open to learning. Now, I have a number of friends in the military, and one who is a previous Blue Angel, and it turns out, if you look at high performance of an elite group of pilots like this, it turns out that their mechanism of learning, the debriefing process, is really the most important aspect of how they improve their overall performance. And if you look in the literature, there is evidence in the literature in the medical domain that examples of perioperative briefing and debriefing do improve patient safety and do improve outcome, particularly with attention made to the debriefing process. And this is an example of a paper where they actually matched the exercise that was going to be done as identical as they can with the performers doing it. And they compared those that had a debriefing process that was thorough and those that did not. And those that had a proper debriefing process outperformed those that did not. Cannot emphasize the importance of debriefing enough. We actually have started what we call a Blue Angel debriefing process in cardiac surgery in a couple of our operating rooms as a pilot. So what is the debriefing? Well, it's not a lecture, it's a facilitated discussion. And right now it's in its early phases where it occurs at the end of the operation, and we go around to each person in the operating room and we ask them through their eyes what they thought went well and why, and what needs improvement and how that could be done. Very similar to the way that the actual Blue Angels do it. And the leader needs to avoid, in our case that would be the surgeon, you need to avoid telling your team members what they believe was done right or wrong. Everybody feels like they can openly contribute, and they need to really self-reflect on their own performance. And the leader needs to be humble and actively involve all team members and obtain and seek their input. And the dynamic of the debrief can be summarized as the following. You want a safe environment where there's respect. You want to have your ego checked at the door, that is, be humble. You want to lay it on the table and be transparent, that is openness. You need to own it and fix it and make yourself accountable. And at the end, we do exactly the way the Blue Angels do, where we express gratitude by saying, we are very glad to be here. What else is out there? Okay, well, it turns out that in the surgical literature, there is an association between surgical technical skills and patient outcomes. And this is a paper that looked at colorectal surgeons looking at a variety of complications, unplanned readmissions, all of the usual variables that we would track for quality, and relate it back to technical skill. And it turns out that technical skills in the operating room do matter, and it does result in all of these sort of untoward events when surgical and technical skills are not optimal. So, what else is out there? There actually is a grading system to evaluate surgeons with their technical skills. The objective structured assessment of technical skills, where we're looking at variables with a Likert scale on 1 to 5 of how the surgeon works with regard to tissue injury, efficiency of movement, fluid use of instruments, smooth transition between steps of the operation, tissue exposure, and an overall summary score. It actually can work quite well and was used in that study. And beyond that, there are the non-technical skills which also play into it. And this is a combination of situational awareness, which we've talked about, critical decision-making, communication and teamwork, leadership, all variables that we've talked about that actually can be graded. In addition to that, the University of Michigan has been looking at automated hand tracking through video. So video, not unlike sports and many other professional domains where you actually go back and review what you did, you actually can, with artificial intelligence, monitor hand tracking, the average time to complete a certain part of the procedure, the acceleration and deceleration of moves, the velocity of actually hand motion, handoffs between the surgeon and the scrub nurse. It's really, really quite fascinating. And you can see right here clear differences between the suturing hand, which is generally doing more, as opposed to the non-suturing hand. So a very, very powerful tool. And you actually can go back and analyze this, and you can get an idea objectively as to the economy of motion and many of the things that we've talked about from a technical standpoint. Really fascinating and something that is here to stay, and I think has a lot of opportunity to help us moving forward. So with that, what's next? Well, this technical and non-technical skills assessment, we are going to start incorporating into the American Board of Thoracic Surgery certification. And we are in the process of putting an NIH protocol together that we're hoping will get funded, where we are going to add this element of assessment to the actual credentialing process. So at the present time, we have a written exam, very much like the American College of Surgeons, that is assessing fund of knowledge and cognitive skills. Then there is an oral exam that follows after passing the written exam. And this is testing critical thinking and judgment. And then once that's done, they receive a certificate and they are, quote, a board certified cardiothoracic surgeon. But there really is nothing along this pathway short of the program director signing off on a piece of paper saying that the resident is technically competent. There are no objective criteria for technical or non-technical skills assessments as part of the program. It's very individualized and program dependent. And there certainly is no assessment during the certification period on the performance of the surgeon. And we've made the analogy, would you ever hire a musician graduating from the Juilliard School of Music without listening to that person play or evaluate how they actually perform? Well, if they have to do things like that, why are we not doing that in surgery? Well, I believe the time is here and we should start doing it. So what we are planning on doing is adding the OSATs, all of the validated domains of what we have just talked about. It's already been adopted in real and in simulated environments. It's out there in the literature. It's here to stay, and I believe it should become part of the assessment for technical skills. Similarly, in high-risk environments, and for astronauts, for oil miners, where this type of technology is being applied, already in place in real and simulated environments, high-risk environments where non-technical skills actually matter in terms of improving patient safety scores or practitioner safety scores. So it will be a combination of technical skills that will be done by video, that will be sent in. There will be a training process for peer assessors to allow reproducibility. And there will be similarly the same thing that happens for the non-technical skills, where there'll be formal training of each assessor so that it becomes reproducible. All of the HIPAA-compliant features are in place, and this will result in a combination of traditional outcomes assessment, which we already do now, and we will add this new novel assessment tool of performance, where we're looking at objective measures in the case of cardiac surgery, echo findings before the procedure, echo confirmation after the procedure that we actually did what we were supposed to do. And the study is going to basically assess the concordance of surgeon expert-based assessments of surgical technical and non-technical skills, and it will correlate it with the training program summation evaluation and ABTS certification decisions. We will determine stakeholder perceived barriers and facilitators of using surgeon expert-based acidios of the video as part of the certification decisions, and we will identify variability in technical and non-technical skills across residency programs and various credentialing institutions. So I will draw you back to where I started, that outcomes public reporting is already present in the cardiac surgery domain. It is soon to become present in many of the other procedural and surgical related specialties. We need to take ownership of it. We need to hold ourselves accountable. So we're going to get there with advanced imaging to help us prepare, deliberate practice to help us improve communication and listening skills, optimizing the whole choreography of the operation, and then good self-assessment and debriefing, and then be open to new ways for the examination and maintenance of certification process. I'd like to thank everybody for your attention, and I'm happy to answer any questions or interested in any comments that you may have. Thank you very much.
Thank you, Joe. Wonderful presentation. Dr. Hill, a question for Dr. Deraney.
Yeah, Mark Hill, Chicago. I think you mentioned that you were a reed player, right? Saxophone.
I'm a reed player, yeah.
Right. Well, curious, you had a lot of analogies to musical aspects here. My father was a jazz guitarist, played with Les Paul and Wes Montgomery and Buddy Guy. And I remember growing up as a boy, he'd always be practicing. And I'd say to him, I said, Dad, why do you keep practicing? You're so good. And he always used to say that it just really improves you. I've had the fortunate friendship and taking care of a lot of musicians from Chicago Symphony as well as rock and roll people, and they always have this passion for practicing. So I have a question for you, sir. Do you think that us as surgeons have that same inherent passion for practicing as the musicians that we see?
It's a great point. I think actually in contrast to musicians, they have episodic episodes of performance. So they're practicing in between the quote performances, the concerts, the recordings or whatever. For us as surgeons, we're actually practicing every day by operating every day. Our performance is every day. So I think we are inherently practicing by operating every day. We don't have these episodic big moments where the performance comes. So we are actually practicing each day. Now, to your point about why do you keep practicing, in the music world, the reason that I keep practicing is fear. I don't want to be on the bandstand, and I don't want to not be able to perform at the level of my peers on the bandstand. So, there's this incentive to practice just out of the fear of not being able to live up to what everybody else is able to do. And to a certain extent, there's an element of that in surgery. But I do think we are, in effect, practicing every day because, for us, showtime is essentially every day with every operation.
Thank you.
I've got 6 questions, but we don't have time for that. But I have time for one from the audience, Joe. One last question.
Okay.
So Scott Steele at the Cleveland Clinic. So for years, the Colorectal Surgery Board took a look, and we did COSATs. We published on it, looking at different, exactly as you said, technical skills. But what we found is that both on the virtual platform as well as the models that we developed, they just weren't high enough quality to truly assess the skills. And my disclaimer is I was a part of Jonah's project in terms of looking at technical skills correlating with patient outcomes, and we used right colectomies. When you talk about incorporating this into a high-stakes environment and continuing with maintenance and certification, a right colectomy is a ton different than something in a pelvic structure. And I'm sure with cardiac surgery, the different types of operations you have. So how do you propose really saying, I'm going to look at one operation or a few videos or anything like that, or a model such as an OSATs and really make that part of the board process, because somebody may be able to do a right colectomy or do something on a model, but you take them in any other environment, specifically more complex procedures, and it's a completely different ballgame.
Yeah. Your point is a good one, and I'm sure we're going to learn, we're going to learn through this. I think that it may ultimately turn out that the quote assessment of technical performance, which is a combination of both technical and non-technical skills, may just be a part of the process that is mandatory, but not a part of the process that ultimately gets factored into the decision about whether somebody actually passes their boards or not. I think the general sentiment is that there needs to be some sort of trail of accumulating information about abilities, that is currently not present, and whether it's, it may end up being lighter on videography because of the points you just made, and it may center more around, a case list with, tracking all of the morbidity and mortality scores to some degree. Time will tell. I think the time is here to at least consider it. How it ultimately gets factored into the equation, I think, remains to be seen based on, what we learn and the kinds of comments that you just made.
It's clear that we can't do nothing, and the journey of 1,000 miles starts with the first step. I think you're 3 or 4 ahead of us. Well done, my friend. Thank you very much, Dr. Duran.
Thank you very much.
At this time,